Hello, this is Kristy Snyder. I'm going to be talking to you about clinical judgment today. We're going to expand on what you learned in first and second semester. So our objectives are listed on this unit outline. We're going to look at assessment data to help prioritize nursing care. We're going to organize the client care and using established priority order for completing responsibilities and interventions. We're going to be discriminating among severities of the client needs. And we're going to think about the interrelated concepts, which is all concepts that you have previously learned. The definition of clinical judgment is an interpretation or conclusion that we find about a patient's needs, their concerns or health problems, and the decisions or the actions that we take or don't, actions that we use or modify from standard approaches or improvise new ones as deemed appropriate by the patient's response. Alfaro Lefebvre that says clinical judgment is ways of thinking about your patient care situations. And in Freiberg, they state clinical reasoning applies the thought processes associated with critical thinking, such as problem solving, diagnostics, ethical and moral reasoning, decision-making, and evidence-based practice to make judgments about each patient care situation. So in one of the case studies, there's a lady named Ellen Kelly. She's 82 years old, and she's going to be your patient for today. Mrs. Kelly lives independently. She's in a senior apartment. She's widowed, and she has two daughters and they're very active and involved in her life. She's not been feeling well for the last several days. She's more tired than usual, more fatigued, and she's been running a fever the last 24 hours. She says that she has painful burning sensation when she urinates, as well as frequency of urination the last week. Her daughter became concerned and brought her to the emergency room because her mom didn't know what day it was, and that's not normally like her. Usually she's very mentally alert and has no history of confusion. So think about that. What's your spidey sense say? What cues did you find in this introduction that were concerning? Look at your case study and think about the cues that stuck out to you to give you clues as to what's going on with this patient and what you need to do for her. This is the model. It talks about Tanner's model of clinical judgment on the bottom. The nursing process is in the middle, and the National Council State Board of Nursing clinical judgment model is on the top. So if we look at all these together with the NCSBN, we're recognizing the cues, which is assessment or noticing. We're analyzing the cues and developing that hypothesis, deciding what's priority. That's analysis in the nursing process. It's also interpreting in the Tanner's model. Then in CSBN, we're looking at generating solutions, which is planning, and also taking action, which is implementation, and then responding in Tanner's. And then all three of them, we have to evaluate the outcomes or reflect on the outcomes. So use this model to help you through working with your patient. This model is found in Giddens on page 389. It's also in your Pearson book, page 2489. Tanner likes to emphasize the ability to think like a nurse. Keith Reischer, in his book, Think Like a Nurse, also emphasizes this. Tanner's model of clinical judgment is a comprehensive approach to clinical judgment. This is the model we use at Neosho. You should be becoming highly familiar with it. Noticing is influenced by the background of the nurse and the nurse's relationship with the patient, as well as the context of the care. The nurse notices various things such as clinical assessment findings, laboratory work, data, patient demeanor, and family situation, And the nurse also looks for patterns that are consistent with his or her previous experiences and uses that information to help guide care. Interpreting is the process of assembling all that information to make sense of it. The nurse draws on a variety of reasoning patterns to interpret the meaning of what has been noticed. Responding, depending on the nurse's level of expertise, actions and interventions are implemented based on patients' needs, or getting help from someone who can determine what interventions or actions need to be done. Reflection in action occurs while the care is being delivered. So we should be constantly thinking about what's going on with our patient and caring for our patient. And we should be thinking about what's working and what's not and what we need to change. Reflection on action is the consideration of a situation after the patient care has occurred. There are 5 rights of clinical reasoning, and this is found in your Think Like a Nurse book, page 149, and especially look at page 153. So you need to think about, where do you get your cues from? And why are they so important that it's listed as number 1 on the 5 rights of clinical reasoning? What happens if you miss a clue early on? A cue early on. If you miss that cue early on, your patient could start spiraling downhill, and before you know it, they're in a code blue situation that we may be able to not pull them out of. We need to think about the right patient. We need to be able to identify which patient is the most critical and at the highest risk for developing a complication. Timeliness of identifying a change of status is so important. Early recognition of complications and then acting on your findings is tantamount to producing good, optimal outcomes for our patient. We need to use the correct interventions for our actions to help our patients have good outcomes. And you want to see page 149 in Think Like a Nurse. The right reason, you have to understand the rationale or the why everything is done in practice. You have to understand why you're doing something and why it's important to the success and good outcome for our patient. Start thinking of yourself as a lifeguard. Lifeguards are continually being vigilant, and they're continually looking out for trouble. They're sitting up there in their chair and they're continually looking for trouble. Trending or looking for early signs of compromise. That's why it's so important to trend those vital signs in your lab work, even previous nursing notes. Anticipate looking for your Jason problem, and we're going to talk about the Jason problems here in a minute. It's really important to be proactive to prevent a possible complication. It's easier to prevent a complication sometimes than it is to correct it. So think about what's the worst possible outcome or the most likely complication that your patient could have. There's a short distance and time frame between the body's ability to compensate and the downward spiral of decompensation. I'm going to play this video and then we'll talk about Jason.
Did you know a young boy drowned here? He was my son. And today is his birthday.
You won't believe my parents' cabin. Very nice, huh? Hey, I'm not from around here, but sister. She's going missing. You seen her?
She ain't missing. She's dead. People go missing around here, they gone for good. We gotta get out of here. Come on, you guys. Oh my God.
This place is called Camp Crystal Lake. You in there? Please, open up! Guys, kill everybody!
His name was Jason, and today is his birthday.
So, Jason, in the Friday the 13th horror movies, is the worst possible outcome. So you have to think about what Jason represents for your patients. Jason is the worst possible scenario for your patient. And you have to think about, when you go to take care of your patients, what could be the worst possible Jason moment that your patients could have. What's going to be something that is going to sneak up and kill your patient before you even know it. You always have to be on the alert for Jason. So think about that every time you walk into a patient's room. Think about, what is that potential Jason that could come out of nowhere and kill your patient? So here are some of the most common patient complications. This is on a table in Think Like a Nurse, page 158. These are the things that we always have to be on the lookout for. Always remember the ABCs. Remember airway, breathing, and circulation. Think about what brought your patient to the hospital. Think about what complications that they've had and what could potentially be a complication maybe of the treatment that we're giving the patient. Failure to rescue is a huge problem in nursing today. According to Gebhardt, McGrath, and Efkin, in their journal article in 2011, it's the inability of clinicians to save a patient's life by timely diagnosis and treatment when a complication develops. This article is in the resources, and it talks about bell curves for symptoms that should cue us as nurses into an impending problem. It talks about cardiac, respiratory, and neurological. It's really important to be trending your vital signs, your patient's health, and their labs to pick up on cues that our patients are trending downward. Here is the neurological bell curve. Again, it's found in the in the article Failure to Rescue, the Nurse's Impact. When we observe the patient, we need to look for those subtle clues that the patient may be starting to have signs and symptoms of some kind of impending problems. Think about your patient who is post-surgical. It's dismissal day, they're getting ready to go home, but you see them being really restless, they're anxious, they're kind of irritable, they might be agitated. And then as the day goes on, while we're waiting for the doctor to write dismissal orders, they say something that leads you to believe that they're confused. Before we get to that point, when they're restless and anxious and they're a little grumpy, we need to be figuring out what's going on. We really need to start looking for cues that maybe their electrolytes are out of balance. Maybe we need to figure out if maybe they're bleeding in their incisional site. Once they get to the confused combative stage, it's going to be harder and harder to figure out what's going on. Then they get to a point where they totally become unresponsive. And once they get to that point, it's hard to bring them back. You want to look at page 156 and 157 and think like a nurse to help answer the questions on your case study patient. So, respiratory cues. Think about what the impending issues are. We know that 20 breaths per minute could be pretty normal for our adult patient, but once they start increasing, or once they start getting bradyapnea, low respirations, anything below 10 is a problem. And it may not be very long before the body goes to apnea. So when they start increasing and they've been 18 to 20 breaths per minute and all of a sudden they're at 24 or 30, we know we need to do something before they get down to 4 breaths per minute and go into respiratory arrest. When we look at those cardiac cues, we want to think about what their pulse rate was before. Do they have a history of dysrhythmias? If they've been running 60 to 80 beats per minute and all of a sudden they're above 100, you want to figure out why. And you might have to put them on telemetry to figure out what rhythm they're in and what problems that rhythm is going to cause. Once you get to a pulseless VTAC, a pulseless VFib, or especially asystole, these people it's extremely hard to bring them out of that rhythm. So we need to recognize problems before it happens. So what is the rapid response team? Rapid response in most hospitals is different from a code blue team. These are teams that respond to a patient. Code blue teams respond to patients that are in cardiac arrest. The rapid response team intervenes upstream from a potential code situation to hopefully help keep our patient from getting there. They rely on bedside nurses who are highly sensitive to signs that a patient's condition is deteriorating, and having a rapid response team empowers the nurse or families to call others into action. I think Joint Commission has that's one of the requirements from Joint Commission, to have a fully implemented rapid response team. And they're usually called about 10 times a month for every 100 occupied beds. So it depends on the size of your hospital. The composition of the rapid response team, who's on it, it varies from hospital to hospital, but there's usually a respiratory therapist and an ICU nurse, and the hospitalist may be part of that rapid response or rapid assessment team, medical emergency team. So think about that when you're in the clinical setting. How do you get a hold of the rapid response team, and when do you call them? I have heard some nurses that say they're afraid to call them because they get mad if they call them if it's not necessary. How do you know if it's going to be necessary or not? If you have that tingly spidey sense, that gut feeling that something's not quite right, but I don't know what to do and I'm really concerned about my patient, find somebody else to help you, even if it's bringing in a nurse that has more experience than you, or another nurse that you trust that can give you their interpretation of what's going on with the patient, a charge nurse. And it's okay to call the rapid response team and have them come up and check the patient over and tell you, I think they're going to be okay. Typically, they have criteria, and the criteria might be a heart rate over 140 beats per minute or less than 40 beats per minute, a respiratory rate over 28 per minute or less than 8 per minute, a systolic blood pressure greater than 180 millimeters mercury or less than 90 millimeters mercury, oxygen saturations that are less than 90% despite supplementation of oxygen, if they have acute change in mental status. It's so important to keep doing checks on mental status. Urine output less than 50 milliliters over 4 hours. A staff member has significant concern about the patient's condition. Some additional criteria, chest pain that's unrelieved by nitroglycerin if it's ordered, or a new onset of chest pain. They have a threatened airway, they are having a seizure, or they're having really uncontrolled pain. So here are patients, a couple of patients, and what we want you to do is identify the pertinent information in these patients. And then I want to know, who are you going to see first and why? And think about the rationale. So pause the video, pause and think about this and write this down. Look at the information and determine what are your cues, what needs to be taken care of, and which one do you need to see first. So you want to think that Mr. J is in the more critical condition. His urine output is 150 milliliters in a 12-hour shift. And think about how much input he's had. His IV is going at 75 mils per hour. So his urine output is less than 30 milliliters per hour, and that's considered, you need to take that into consideration. So he should be the priority patient because his kidneys are not functioning. Mr. H, he's been in the hospital for 3 days. He's been receiving IV antibiotics. He's already had Tylenol for his fever. His O2 sats are 94% on room air, so that's all right. His IV is infusing. He's coughing up thick white phlegm. That's good. His intake and output is good. So Mr. J is the more critical of the two patients. Let's talk about this patient. So I want you to think about prioritization of your nursing interventions. Pause the video, read the scenario, and then look at the list, the 5 nursing interventions that you need to prioritize. So the 5 nursing interventions, I hope what you picked first was take an initial set of vital signs, assess the pain level, and look at the pulse oximetry. Then you want to pick up the blood from the lab. You verify the doctor's order, the blood compatibility, and the patient ID with another RN at patient bedside. You need to do that point of care patient identification. Then you'll assess the IV site and start the transfusion. So it's really important that you do that initial assessment before you even go to the lab to get the blood. This is so important because we want to make sure that our patient is, what's going on with our patient before we give the blood. So in thinking about clinical judgment and clinical reasoning at the bedside, you want to think about what cues you need to be watching out for. And if you have cues, what are your interventions? What are you going to do to correct those? Think about that neurological bell curve and how your patient, that anxiety and restlessness can be your first cue that something's going on. And to recognize that and to figure out what is going on to keep them from going unconscious and getting in a code situation. So do the case study on Mrs. Kelly and think about those cues that you need to pick up. Prioritize the interventions and what you need to do first. Think about what you might need to look at as far as trending, and then put it all together. The questions on the test will be clinical judgment questions about patient care scenarios, and there will be prioritization questions. If you have any questions, just let me know. Have a good day.